Hello, everyone, and welcome to today's live broadcast, Emerging Trends Cell-Free DNA-Based Screening for Common Aneuploidies, presented by Glenn Palomaki. He is a professor at the Department of Pathology and Laboratory Medicine, Women and Infants Hospital at Alpert Medical School at Brown University. I am Marjorie Torres of LabRoots, and I will be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box that appears on the screen. We'll answer as many of your questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, please click on the Help Desk button located in the promotional board at the bottom or center of your screen, or use the Ask a Question box to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. Please join me in welcoming Dr. Glenn Palomaki. I will now turn the presentation over to him.
Hello and welcome. I'm Glenn Palomaki, and I'm giving you a presentation today about cell-free DNA screening for common autosomal trisomies and other disorders, as well as emerging trends surrounding that, so you get an idea of what might be coming in the near future. The disclosures are there. Essentially, everything goes through my hospital. I don't have any personal contracts with anyone. And our outline, the main part of the talk, the first four bullets, have to do with really cell-free DNA, first five maybe, and then the last four have to do with kind of competing models or methodologies that somehow might merge together with cell-free DNA testing in the near or longer term future. So let's just start off with kind of an introduction to this, and even as background, going a little bit further back, where were we in 2000 scene? And the best screening test that was available back in 2010 was a combination of both first trimester and combined tests like nuchal translucency, PAP-A, and free beta, added to the quadruple test in the second trimester, which is AFP, UE3, HCG, and inhibin, which creates what's called the integrated or sequential test. And at roughly a 1 in 100 cutoff, you can see the little vertical line here. These are the overlapping distributions. Here are the normal or euploid pregnancies with 1 in 10,000, very low risks. And here's the Down syndrome distribution with very high risks. The cutoff is about 1 in 100. And you can see that only this little portion of the euploid pregnancy would be screened positive, while the vast majority of the Down syndrome are screened positive, roughly a 90% detection rate for a 2% false positive rate. And that's really a pretty good prenatal screening test. It's about a 45-fold increase in risk on the woman's age if she's screened positive. So that's where we were. It's a pretty good test, but it could always be improved. Whoops. And it was 1997, Dennis Lowe and colleagues at Chinese University of Hong Kong had a paper in the Lancet where he took plasma from pregnant women and simply had a Y probe, and the male pregnancies, they all showed the Y probe mark, and the 4 subsequent samples were from females. They didn't, and he made the link that if there's Y material circulating in a pregnant female, then the fetus must be male. And of course, those 3 delivered a male and the other 4 delivered a female. So this showed that there was circulating fetal placental DNA in the maternal circulation. But there was not much you could do with this except perhaps determine the fetal sex until there was more work done in next generation sequencing. So let's just look at some of the characteristics of this cell-free DNA. So there's cell-free fetal, cell-free maternal DNA that circulate in the plasma. Now, we always call it fetal DNA, but we know now it's placental in origin. So if you think of cell-free DNA as a test, it's more like a CVS, which placental materials, than like an amnio, which is taking fetal material. So the maternal DNA comes mainly from the circulatory system. The cell-free and maternal DNA are all quite chopped up, averaging something perhaps 150 to 200 base pairs, but as small as 50 and as big as perhaps 300-400. And they represent the entire genome. I'll show you what that means in a minute. But what's really interesting is the last bullet. You may know that fetal cells are 1 in a million, 1 in 10 million circulating cells, but fetal DNA is about 10% of the total circulating cell-free DNA. So if you were to select 10 fragments of DNA from the circulation, it's likely that one of them will be fetal placental in origin. The other 9 will be maternal. And we'll see that this ratio of fetal to maternal, or the fetal fraction, turns out to be an important variable in this testing. So there's some information about cell-free DNA. Now, this is the human genome ordered by chromosome. You know, 1 is the largest, and this gives it in megabases, or the percentage of the genome. So the first chromosome is about 8%, and the 21st chromosome, try and stick this number in your head for a little while. It's going to come back about 1.5%, relatively small amount. So only 1 or 2 fragments per 100 are going to be coming from the 21st chromosome. So these fragments in circulation represent all of these chromosomes in roughly not actually roughly, but almost exactly the proportion that it should be. So now I'm just going to go through what's called shotgun counting sequencing to test for common trisomies. So this is a representation of the fragments in the maternal circulation. The red represent the fetal, the black, the maternal. This is a blood, I guess this is the needle. This is a nice set of schematics that Rosa Chu, again from Chinese University of Hong Kong, put together. So this is going to sample these fragments and sequence them. And they're going to sequence in 36 base pairs. And there's nothing magic about 36 base pairs. The point of sequencing some part of that fragment, again, that fragment might be 150 base pairs. What we're interested in is, what chromosome did it come from? In this case, the 36 base pairs mapped uniquely to chromosome 7. So if you think about it, if you're going to sequence 1 million fragments, it means that 1 million times you're going to have to do an alignment with the human genome and try and figure out, is it on chromosome 1, 2, 3, 4? Oh, I found it on chromosome 5, I can stop. No, you can't, because that might be duplicated on chromosome 11. So every single sequence has to be checked against the entire genome, and you can see that's a lot of bio. Why don't you sequence less? Why don't you sequence 15? It would be faster, wouldn't it? Well, if you sequenced only 15, there would be a lot of matches, and they wouldn't be unique. And you say, well, then why don't you sequence 60? And the answer is, well, then you're using up a lot of additional sequencing and expense, and it really doesn't get much better. So could you do 34? Sure. Could you do 41? Sure. So there's no magic to 36, but the point of the sequence is to try and uniquely describe that fragment to a chromosome. Then the next step is simply a bean counting. So in this case, you do a sequence and you can see that there are 6 of them that go to chromosome 1, and so on and so on and so on. And if you're really good at it, you'll see that there are 51 dots, and you go to the 21st chromosome, and there's only 1 fragment that mapped to the 21st chromosome in my first 51 fragments. Well, that's 1 out of 51, which is 2%. And do you remember what we thought it ought to be in the genome? it ought to be 1.5%. So by counting only 51, we've actually gotten pretty close to the right answer. But you can see if we want to get a really good estimate, we got to count a whole lot more than 51. You have to count not thousands or tens of thousands or hundreds of thousands, but millions of fragments. All right, so let's say that you have sequenced and aligned millions of fragments. How do you test somebody then? So you figure out how many fragments map to chromosome 21 for the woman, the patient, whatever you want to call, and compare that to the mean. I said it's about 1.5%. It isn't exactly 1.5, but 1.5 will work. And then express it as a z-score. Well, that sounds like math, so we better go through this a little bit. So let's say that I have already sequenced a number of normal euploid pregnancies, more than just 6, but I'm just going to display 6. Let's say I did 100 or so. And I calculated the average as 1.5, and I calculated the standard deviation. And this standard deviation has one of the early, was next-gen sequencing going to be precise enough to do this sort of testing? Excuse me. So if this is very tight, this might work. And let's say then I get a 1.59%. Ooh, that's a little bit above 1.5. Is that high enough to say it might be trisomy? There might be some extra material from the fetus that has 3 21 chromosomes? And the answer is you go to the z-score calculation, which is simply what's the patient's value, 1.59, minus what I expect to get, 1.5. That distance expressed as standard deviation units. So it's 0.09 divided by 0.02 is 4.5. And if you remember back from your statistics, anything much more than 2 or 3 SDs is highly unlikely to have occurred by chance. So this finding says, this looks like there's way too many 21 chromosome fragments than I would expect. And you can say that's consistent with the fetus being affected with Down syndrome. And this is from our large external validation that started clinical testing back in late 2011. Here is those 21 chromosome 21 z-scores that I just showed you how to generate. If you drew a line at +3 and -3, you would expect your euploid pregnancies, the blue dots, to fall somewhere between ±3 standard deviations. Pretty unlikely to be above, but if you look real carefully, there's 1, there's 2, there's 3. So 3 out of about 1,500 would be falsely positive. So this cut off the red dots are the downs, and you can see that there are 1, 2, 3. Actually, there's 4 below, but only 3 of them were actually falsely negative. You also, if we look at the x-axis now, what's the x-axis? It's the fetal fraction. Remember, we said that the average is about 10%? Well, there's the 10% fetal fraction. And you see as the fetal fraction goes up, in other words, as more and more of the material that you're testing comes from the fetus, it becomes easier and easier to separate the normal from the Down syndrome. And if we go down to the other end, you see all of the errors occurred at fetal fractions that were 4, 5, 6%, and say, well, wait a minute, I don't see anything below 4. Well, all the samples below 4 were called test failures because they weren't confident that they had sufficient information to make a call. So with very low fetal fractions, 1, you might have failures. 2, that's where you might have false negative results. Now, what I have to tell you is this was all done in testing was 2000. Actually, it's more than 6 years old. The testing was done in 2010, so it's actually about 8 years old now. So this is what testing was like back in 2010 before it was even clinically available. So things should have gotten a bit better, and I think they have. Now, if we kind of compare the graphic here with the graphic for integrated testing, so this is cell-free DNA in the maternal plasma, very high performance. We found just over 98%. I think nowadays it's more like 99%. We had about 0.2, 0.3% positive. Now it's down around 0.1, 0.2% positive. And you look at the distribution of euploid, it is very tight. Notice it's not centered at 1.5. I lied, it's 1.372 something or other, but that's too hard to remember. So you can draw a cutoff at roughly 3 SDs. That's what this corresponds to. And if we were to zoom in here, you can kind of see, yeah, okay, there might be a few false negatives, there might be a few false positives, but it's almost diagnostic. And you'd say, well, is this test diagnostic? And the answer is, we have a lot worse tests that are called diagnostic. The only reason this is not diagnostic is because we have a better test than this, and that's amnio-CVS karyotype microarray. We do have a kind of true diagnostic test. So this has to still be considered a really, really good screening test, but not a diagnostic test. Screen positive results should be followed up with the offer of amniocentesis and karyotyping, or CVS and microarray, or something like that. So what I just showed you was called a shotgun counting. You can see why. There are other methods. I'm not going to go into detail, but there's some methods that say, well, you know, why are you sequencing chromosome 1, 2, and 3? I mean, we're only interested in 21, 18, 13, and maybe X and Y. So I'm going to create a method where I only pull out fragments from what I'm interested in. I have to do a whole lot less sequencing. But then I still count the same way as I did before. So instead of shotgun sequencing, it's targeted sequencing. That should be a little less expensive, but you'll see you're limited as to what you can find. If you wanted to find trisomy 16, you can't do it here unless you add some targets for chromosome 16. Here, you could find chromosome 16 if you wanted to do by just doing some extra, mathematics. The data are there. And then there's a completely different method that uses SNP pattern matching. So it selects SNPs spread across chromosomes 21, 18, 13, X and Y, or whatever else you want. And then rather than counting, it's looking at patterns. And it gets a bit complex, but it's more pattern matching than it is counting. I think I'll just leave it there. But there are other methodologies. They all work. The information is there in the cell-free DNA. All you have to do is figure out clever ways of testing for it. So now we'll look at testing in the low-risk population, because testing in the high-risk population started being recommended back in 2012. Once ACOG and others found out that the testing actually is reliable. There are some false negatives. There are a few false positives, but very, very few. So women who are, let's say, over age 35, with a risk of about 1 in 150 for Downs on average, you could test those 150 pregnancies. Of the 149 that didn't have a pregnancy with Down syndrome, remember, only 2 or 3 per thousand. So in 150 women age 35 and older, you might have no false positives. And there's a 98, 99% chance that you'll identify that one Downs. So the vast majority of the 150 women would get a great reduction in their risk for Down syndrome. And when I say Down syndrome, I don't want to have to keep tagging on trisomy 18, trisomy 13, but they're perhaps not quite as good a test, but they're still, it's really very good. And so if you do look at high-risk women like over age 35, ultrasound abnormality, family history, this test is being used basically to reduce the number of women that need invasive testing. So if you know that this woman's at very low risk because she has a negative cell-free DNA test, she may choose not to have amniocentesis. And they recommended at that time not testing twin pregnancies. There's more data now. It seems to work reasonably well. I'll talk about microdeletion and sex aneuploidy a little bit later. But in the high-risk population is pretty well set. If you had a test failure, it was pretty straightforward anyway. They were already at high risk. You already talked to them about invasive testing. So if your cell-free DNA test happened to fail, you could say, well, we could try again. We could get a serum test, or you know what? You could just have invasive testing because you're already considered to be at high risk. So how does testing in the general pregnancy population differ from the high-risk population? Well, the first thing is the predictive values. The test has the same detection false positive rate, but the prevalence is much lower. So in the high-risk population, the positive predictive value could easily be 7 true positives to every 1 false positive, or 5 to 1, or 9 to 1, or something. In the low-risk population, it's unlikely to be that high. It might be 1 to 1, it might be 3 to 1, 5 to 1, but they're going to be more false positive results. And so the test is still working the same. There's just less to detect. In fact, if I had a perfect test, 100% detection rate and no false positives, what's the predictive value in a population that doesn't have the disease? The answer is the predictive value is 0. It's useless because there's no disease. So the predictive value is a combination of detection, false positive, and prevalence. And I just mentioned this. What about test failures, no calls? In the high risk, they're already offered diagnostic testing, not much of an issue. But in the low risk population, is the best thing to do just say, oh, go have an amnio? Well, maybe not. Maybe there's some other options like repeating the cell-free DNA or having a high-resolution ultrasound, level 2 ultrasound. And what about counseling and education? In the high risk, those women are likely already seeing a genetic counseling or a genetic specialist. In the low risk, there's simply too many people in the general population. It was the initial counseling and description of the test and whatever, I think would really have to come from primary care providers. And that was the point of a study that we did in Rhode Island. I'll just show you a little bit about that. The aims of the study, it's a demonstration project, mainly having to do with clinical utility. We weren't really testing, does the test work? We were really testing, can we introduce this test with the primary obstetrical care providers doing the initial counseling. And so we made sure we had good patient educational materials. We worked with the providers. We did surveys to document that. We told them they were going to improve the detection rate and reducing false positives. But you know what's the same? When they got a screen positive, they did the same thing with a screen positive for cell-free as they did with a screen positive for serum screening. They referred it. Now they had to say the right sorts of things, but actually what they had to do was pretty much the same as before. They had to maybe, say the word cell-free DNA now, and they had to learn a little bit more, but it's really not that different for introduction. Optional detection of sex aneuploidies. There were no financial barriers here. We offered free testing for 9 months to anybody who wanted it. Even the insurance was not billed. And I'm not going to address the last one. So there was the booklet, and it was at the 8th grade level. SAM criteria was met. It had all the content that was recommended at the time by the professional organizations. And the only thing I'm going to really focus on here is uptake and what we found. So there were really 7 large group practices in Rhode Island. Rhode Island's a very small state, but of the 7 large practices, 2 said, I'm not interested. ACOG says you shouldn't do this in the general population, which was true in 2014 when we did this. Or they thought, oh gosh, DNA, this is too much. But 5 of them said, yeah, sure, we'll give it a shot. And all of them received in-house training. Those 5 centers ended up enrolling 82% of the women. So they were the majority group as expected. And the last one I'm going to show you, they exceeded the number of women who had serum screening in the previous 6 months. This is the advantage of looking at the large practices. We had a very good fix on how many pregnancies they were screening in the previous 6 months, a weekly rate. I think all of these practices enrolled more than 50 new pregnancies per month. So here we have the week of enrollment of the study versus the ratio of testing. Now, what that means is that this line at 100% says if I have a dot above that line, I'm sorry, below that line, it means that the integrated test, that was our main test, is the primary test. DNA first, or the free DNA test, is now the primary test. I should say, DNA first was the idea of you're using DNA as the first test in the first trimester. And so most of these samples were in the first trimester. So here we have one site. I kind of gave it as a dashed line. They started at week 1. They were doing more serum screening than they were DNA screening in the previous 6 months. But look, by the 6th week, they got over 100%. In other words, whatever their previous 6-month average was, they were now about 10% higher than that. And there's where we start counting. And then we look at what they did after that, up to the end of the study. And the average there was 30%. So they actually ended up screening, once they got the hang of things, 30% more women than they had in the previous 6 months. That's a big increase. And you know, there's questions about, well, where did that increase come from? Here's 2 more early adopters. We call them early adopters because they started also at week 1. This group very quickly by week 3 exceeded and ended up with a 13% higher rate. This group, you know, had some struggles, and it was really not until week 13 that they broke the barrier of 100%. But then from then on, they averaged 14% above. Now here are the last 2. They're called laggards. People who are late in adopting. I think laggards is maybe a little pejorative. So I said they're the later adopters. And you see, they didn't even try until week 15 or so. And they heard the other practices were doing pretty good by week 15. They said, we better get going. Well, it only took this site 1 week to get up to 100%. And this took this one only about 3 or 4 weeks to get up. This was a plus 40%. This was a plus 8%. So all 5 large practices ended up testing an average of more women with cell-free DNA than they did with serum screening. So not only is cell-free DNA a better test in higher detection, lower false positive, it also appears as though more women and more providers, once they're informed, are interested in offering and receiving such testing. So what happened? Well, overall, 2691 women enrolled. 19 of them never got an initial test result, mainly because FedEx lost one of our packages that was being sent to the laboratory. We didn't do the testing in-house. It was done in a commercial laboratory. But 13 of those 19 came back later. This is depressing that, you know, a woman wanted to have the test, and there was either insufficient volumes damaged or it got lost, and 6 of them just kind of gave up. That's unfortunate. 13 came back. So this number of women got tested. We were using the SNP methodology. This was a study funded by Natera. And they, at the time, could not do twins. They do now, and they can't do a pregnancy where the mother is not related to the fetus. So these really should never have been tested. So we only reported 2,681 test results. So what happened in those test results? There were only 16 screen positives. Only 6 per 1,000 women were screen positive. And if we look down here, all of them got genetic counseling. There were 9 trisomy 21 positives, 7 were true positives, 2 false positives, 318, all were true positives, 413, 2 true positives, 2 false positives. So if you wanted to look at the predictive value, it's 12 to 4, which is about 3 to 1. And this is a general population. You don't expect the positive value to be terribly high. It's not going to be 90, 95, 98%. It was 75%. That's probably about where you expect. The false positive, those 2 plus those 2, 4 out of 2681, or about 0.15%. So the performance was kind of as expected. So what did the women do? As I said, they all saw a genetic specialist. 75% of them, 12, chose to have a CVS or an amnio. I think most of them were amnios. That's where 3 false positives and 9 true positives were identified. 7 terminated. 1 was an intrauterine fetal death, and 1 was a live born. On the other side, 4 of them did not choose. There was 1 false positive, 3 true positives. That ended up having, normal birth exam, 3 true positives, 2 diagnosed after birth, 1 IUFD that was karyotype products of conception. So in the general population, which is, where we have to think about going in the future, high risk is pretty well now established and reimbursed by insurance companies. But what about the general population, and what are laboratories and people doing about cell-free DNA testing? Well, what's happening is they're looking at additional targets, and sex chromosome aneuploidies turn out to be one, which, there's monosomy X Turner syndrome, which you can identify with oftentimes a high NT measurement, and then the 3 common sex trisomies. And obviously, if you're going to do sex chromosome aneuploidies, you're going to figure out what the fetal sex is. And that's something that, a lot of couples want to know early. They're going to find out via ultrasound or some other method what it is. I'm not terribly concerned about them figuring it out, at least in the United States early. In China, you're not allowed to report anything but a sex chromosome abnormality. You can't report a normal male or female. But anyway, I don't know if, there's arguments about, are these serious enough to identify? On the other hand, if you don't identify them prenatally, right now there's no way to identify them at birth, and many of these are identified not until much later, when it's past the time. They might have some treatments that would ameliorate some of the symptoms. So, this is not unreasonable, but it maybe should be an option. Now, those groups that are doing shotgun methods, they can find other things, as we said earlier, like trisomy 16 or trisomy 2. The problem with this low resolution scan is, what exactly are you supposed to do with the knowledge that there's a trisomy 16? Because clearly the fetus is not trisomy 16, because that's not compatible with life by the time you're at 12, 14, 16 weeks. It must be confined placental mosaicism of trisomy 16. And yes, there might be some low birth weight, preterm delivery, and you might want to watch more, but that's questionable. But again, that's what people are doing. They're also starting to do microdeletions. Now, I hate using the phrase large microdeletions, but that's essentially what they're doing. They can only find microdeletions that are 2 to 3 megabytes or larger. Some of them, like Krita Shah, I think is 10, 12 megabytes. I mean, you can see that on a karyotype. So they're looking for common ones like DeGeorge syndrome and or large ones. DeGeorge, I think the critical region is only 1.5 or 2 megabytes. That's about as small as most of them can go. Unfortunately, the detection rate may not be that high. There's a higher false positive rate, a lower predictive value. Some of these things, like the sex chromosome aneuploidies, laboratories really don't need to charge more for, but microdeletions, most are adding an additional charge. So the test is identifying more disorders, but it's starting to cost more as well. And it's already a relatively expensive test. So what about these things? What about if you have an ultrasound finding like a conal truncal defect and or a family history of DeGeorge syndrome? Is this what you should do? Well, let's look. If the DNA test is screen negative, you probably ought to do targeted testing anyway, because cell-free DNA is not going to identify 100% of those microdeletions. Some of them, 1.5 megabases may be missed. So even if it's screen negative, you ought to be doing further testing. What if it's screen positive? Well, screen positive, there's already documented cases of false positives, deletions that are close to the critical region but don't include it. So you have to do further testing. So why are you doing cell-free DNA testing if, regardless of what you get for an answer is, you have to do the targeted testing? And when you have ultrasound findings, there may be microdeletions that have similar ultrasound findings that are not even being tested for. And these low resolution whole genome scans may have an abnormal finding and you really don't know what to do with it. So it's a trisomy 5, and you say, well, what's the possibility? Well, there could be uniparental disomy on chromosome 5, and you look up, well, what's the literature say about uniparental disomy of chromosome 5? And the answer is nothing. I have no idea what it is. All right, so let's talk about less costly and complex methods, because I gave you some of the differences between screening in the general population and the high-risk population. But what I didn't focus on is in the high-risk population, the cost of your DNA testing is kind of offset by the cost of invasive testing, which is quite high. So it makes sense to offer it, because for every woman who does not have an amnio because she has a negative cell-free DNA test, you save $1,000 on the amnio karyotype, but you spend $1,000 on the DNA. So it's a wash. But in the general population, first, there's 4 times as many women in the general population than the high-risk population, and there are fewer costs to offset. So one thing, and I do think that plays into the recommendations of should you routinely test in the general population, and why insurance companies are hesitant to cover general population cell-free DNA testing. Well, there's 2 groups that are active in that area right now. One is a group in Germany, Life Codex. They have a test called QNIPT. This is right out of, I don't know, Genome Web or something. Life Codex got a CE mark for this is a pure methylation-based test. And it says it's going to be cost efficient and rapid. Now, I don't have that much information about how cost efficient and how rapid, but I think they were targeting things for this test costing under $100 and being able to be done in a day. Unfortunately, singleton pregnancies only isn't that big of a difference, but it's only good for trisomy 21. It won't identify anything else or fetal sex. But to show that low cost and rapid it may be, it's licensed by LifeCell for use in India just last year. So, people are thinking about trying to get something less expensive. The second one, this study just came out in the last month or so. And this is a non-next-gen method. And I'm not going to go through the methodology. You can look at this. Actually, if you look at the report, you can see the discussion that has to do with it. But it uses rolling circle amplification rather than PCR. And this set of colored dots looks a lot like what you might see from an Illumina platform, but that's not the sequence of a single base pair. Each one of those is the color of a fragment. So the 21 fragments might be red, the 18 fragments might be blue. And so you just put this into a scanning microscope and simply count the number. So this is a targeted counting method that does not use PCR and does not use next-gen sequencing. And I have to acknowledge here that we were very interested in this, and we have a contract now to do a clinical trial in Rhode Island with this methodology because we think it might be a whole lot less expensive, far less tech time, far less reagents, far less equipment. Just a question of, does it work as well? Now, there's a group who are arguing that cell-free DNA is really robbing women of a really good option, which is diagnostic testing. Why screen if you can know the answer? And these groups make the chromosomal microarrays, are far superior in identifying deletions and microdeletions than a karyotype is. There are, I think, reasonably good arguments that the procedure-related loss of an amnio or CVS is relatively low. I took this right out of one of their papers. It says 1 in 5 or less in expert hands. You do have to note that it's becoming difficult for obstetricians and MFM to train for amnios because there's so few amnios being done now. So I agree with this, perhaps 1 in 500 in less than expert hands, but these experts are starting to retire. CMAs, find everything that a cell-free can find right now, a CMA can find. including the off-target chromosome. So they can do all the microdeletions, not just a subset of the large one. They can go down to very small microdeletions, microduplications, large deletions, and duplications. And there's pretty good evidence from an NIH study that you get serious or profound disorders can be identified on a CMA for these microdeletions and whatever in up to 1.5% of pregnancies. Yeah, it's really surprisingly common. So here's just some things from the supporters. You can read them. You know, again, there's some Mark Evans and Ron Wapner, Berkowitz, basically saying, well, microdeletions are really common. Women should be told that there are a lot of other serious things, and they should be offered the opportunity to have an invasive test with a chromosomal microarray, and that over the next few years, more and more women will become educated such that the pendulum may swing back from cell-free to CVS CMA. Of course, the issue is, even if women understand it, are they going to choose to have this invasive procedure? That's been the issue all along. Even if the risk is 1 in 500, what's their decision-making going to end up with? And there are people who argue on the other side that cell-free DNA shouldn't be seen as a threat. And you know, there are economic and ethical consequences. You're making the presumption that you know, you need to test every normal infant in uncomplicated pregnancies with an invasive diagnostic test. It medicalizes pregnancy more perhaps than is necessary. But for some women, they admit, you know, they want everything, and it's important. And one of the challenges, as we can always say, is to make sure that women are sufficiently informed that they make the choice that they're most happy with. And we may be shortchanging a bit the information about diagnostic testing. Now, what about other types of genetic disorders? Autosomal recessive orders. Well, as you know, historically, these were race or ethnicity based. Caucasians and Jewish populations were tested for cystic fibrosis, the CFTR gene. It's really quite common. And African Americans and Asians sometimes for sickle cell disease. But then there was a question of, well, what about mixed ethnicity? Although cystic fibrosis is more common in Caucasian and Jewish, it still occurs in other populations. You know, and now that we're able to do more cost-effective screening, of more considering pan-ethnic screening, and whether testing should be done preconceptually or prenatally, the disorder should be serious enough to consider termination. Currently, many of these programs that are testing for 50, 100, 150 recessive disorders are moving from the targeted mutations to just sequencing the gene. So instead of looking at, for example, in CFTR, you know, 102, the 23 from ACMG, or the 100 and whatever that are known to be deleterious, they'll just sequence it and use their next-gen sequence variant calling algorithms to determine whether it's pathogenic or not. But there are, you know, generally patients can't choose what's on the panel. The panel's there. They could have a small panel or a big panel, but they can't say, well, I'm really interested in disease ABC. And when you get to 150 diseases, I'm not sure patients would be capable of deciding which ones they want or not. But if you keep it with sufficiently serious to consider termination, I think that may be the way to go. Another thing that's interesting is in doing this testing in the population, it's surprising how often they identify the mother or father as being homozygous or compound heterozygous for one of these, for CFTR. They might have a real deleterious mutation and then a moderate mutation, and now you're into counseling the parents about things, and also screening for diseases that are less severe. You really want to, I think, try and avoid that prenatally. But how does this maybe come into CF? I thought I'd just give one example here The DHCR7 gene is associated with, Smith-Lemli-Opitz syndrome. And I'll just point, so here you go. I guess I should tell you what this is. This is kind of a box of all that one of the panels can identify. And you see cystic fibrosis is 39% of all the affected, it's 32 per 100,000 or 17% of all the profound serious disorders. This is the hemoglobinopathies. The green are special cases you can't really do with next-gen sequencing, Fragile X, and so on. But I'm picking Smith-Lemli-Opitz just as an example. It's a pretty big box, and you say, wow, I didn't realize Smith-Lemli-Opitz was that common. Well, it's autosomal recessive, some mildly affected individuals, most severe cases. The carrier frequency in Caucasians about 1 in 60, which says there should be about 1 in 14,000 couples that have a conceptus with SLOS. But the birth prevalence is 1 in 20 to 1 in 60,000. And we did a study in the second trimester where we could identify most SLOS cases through the serum screening program. And we came up with, even accounting for the ones we couldn't find, it's probably only about 1 in 100,000 births. Well, why the discrepancies? There's more and more information coming out that obviously the carrier rate gives you the conceptuses, but there's very high early fetal loss. So the carrier frequency is not predictive of SLOS, even in probably the first or second trimester, much less at birth. So if we go back to this box is actually way too large. This box is really way too large because it includes trait carriers as well as those that are severely affected. So you have to be a little bit careful with some of the numbers that get thrown around for the number of affected individuals or affected fetuses identified, but still, most of them are correct. Now, autosomal dominant is interesting. It's something that actually can be done both with expanded carrier screening and with cell-free DNA. There are about 10 to 15 disorders that are included on cell-free DNA panels here and there, including, I've listed 4 of them here. Unfortunately, there isn't a lot of information about how well they're identified. Elevated NT, as we talked a little bit of before, is a marker for Noonan syndrome, but should you use this test for Noonan syndrome, or should you use a more sensitive test? So there's questions about the predictive value. And interestingly, the cost of this test probably is more than an expanded carrier screen, which will test for a whole lot more disorders right now. So although it's possible to identify some, I'm not sure it's competitive right now, but it is being offered. Now, there's also a few groups that have played around with high resolution whole genome, whole exome of the fetus based on cell-free DNA. Now, I'll do the classic, I know you can't read this, because even if you could read it, I'm not sure I could explain it to you. But this was a study back in 2012, Stephen Quake and his group from California. But the thing I want you to really focus on is current cell-free DNA sequence about as few as 2, and some groups sequence perhaps as many as 20 million fragments. This is 930 million fragments. This is not something that's going to be cost competitive in the near future. But it did work, and they showed that it did. This is one that was actually earlier in 2010, and I just show you this because they actually did 3.9 billion aligned reads, about a 65-fold coverage, and I think they were trying to identify, the fetus. The parents were carriers, and the fetus was heterozygous for beta thalassemia. So they actually could make a kind of a fetal diagnosis based on this whole genome. So the 3 colors are the fetus, the mother, and the father. I'm not sure which one's which. And this same group, a group from Chinese University of Hong Kong, now has an updated method that just came out in 2016. And they went from 65-fold, which I just showed you was 9.3 billion reads, to 230-fold coverage, which is what, about 4 times more. So instead of 9 billion, it's now 36 billion aligned reads are needed in the second generation. But they actually showed that they could identify mutation, about 80 to 85% of mutations that would be identified using a whole genome scan on pure fetal material. So they're getting pretty close to identifying most of them. And the positive predictive value was up in the 60, 70%. So when they found one, there was a 60 or 70% chance that it was true, which is okay. But you can see that this is not something that's going to be in general use in the near future. Now, what about fetal cells in maternal circulation? You've heard about this before as well. Well, what would be the advantage of this? I should say advantages, really. Well, one of the disadvantages of fragmented cell-free DNA is it's not it's the whole genome, but it's not intact. Well, a whole fetal cell would have a completely intact fetal genome. It would be much easier to identify copy number variants. And things like for recessive diseases, you don't need to screen the father. You could imagine something like, I collect plasma, I test the cell-free DNA for carrier status of the mother, or the Buffy coat for the carrier status of the mother. And for anything that she's a carrier for, I'll test the fetal cells to see what the fetus is. There's no need to worry about testing the father. And the questions of non-paternity with the father. You only need to test really the mother or the fetus, or really the fetus alone, but the mother and the fetus might save you some time and effort. Well, there's what are some of the issues there? Well, there's stories about, circulating male cells from a previous pregnancy when the current pregnancy is a female. Early in pregnancies, it may be difficult to capture any or only a very few fetal cells. And this is a lot of work. It could be that it's going to be quite costly. I don't know anyone that's actually offering this right now as a routine test. Well, the first group that studied this back in 2002 was the NIFTY study. They often couldn't get fetal cells, low detection, high false positive rate. The likelihood is that some of the cells they were collecting were not actually fetal cells. And from 2002 for about 10 years, very little, almost 15 years, no, not 10 to 12 years, very little was done with fetal cells. But recently, there's been a lot of work with it, just because there's been so many advances in molecular diagnostic and molecular techniques. I've just chosen 2 of the more recent ones. This group identified between 14 and 22 nucleated red blood cells in, I don't know, is it like 15 pregnancies? And they also looked at cytotrophoblasts, where they got 1 to 44, using 4 ml of maternal blood, which is kind of what is used for cell-free DNA. They did it at 11 to 13 weeks, which is kind of the target area you like. They performed FISH and array CGH after whole genome amplification, and they had a 21, an 18, and a 13 in their group of 10 to 15, and they correctly identified all of the cases. And this is clearly proof of concept. This other group, fetal nucleated red blood cells, they were at 18 weeks. They had a few more affected samples, 21s, 18s, 13s, and 2 sex chromosome aneuploidies, and got all of those correct. But again, this is labor intensive, expensive, but it may be on the horizon as another option. So in summary then, current cell-free DNA for the common autosomal trisomies or some of the other aneuploidies, high sensitivity and specificity. It's tending toward including more targets at higher costs. This is the same thing that's happened to computers. Remember, you could have from 20 years ago, the cost of that computer is probably $2, but no one wants what that computer can do anymore. They want a computer that does more. And it's the same trend here. It turned out to be the same thing with cystic fibrosis screening. Could we get the cost of testing 23 mutations down low? And the answer was, it was not easy to do because companies wanted to compete on numbers of mutation rather than cost. And the same thing seems to be happening with cell-free DNA. The competition is what can I find rather than what the cost is. But in the third bullet, that says, well, doing that kind of competition, it may be difficult to transition cell-free to the general pregnancy population. That's what we're going through right now. The tests are really good. They're finding more things, but they're getting more expensive rather than cheaper when you find all those things. They can identify some dominant. They can't really do recessive very well right now. Prenatal diagnosis with the microarray I showed is far better. It's diagnostic, and it finds more certainly of the duplication. Deletion. They find the duplication and deletion disorders. Cell-free really is only focused on the deletions, larger deletions right now. In-depth whole genome using cell-free DNA is possible, but it's very expensive, and same thing with cell-based testing. Again, it's promising. There's some interesting things that you can do with it, but it needs further development and questions about cost. So I think that that does it. I thank you for listening and hope it's been helpful.
Thank you, Dr. Glenn Palomaki, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please type that in. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type your questions into the box that appears on your screen and click the Send button. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, shouldn't all pregnant women have genetic counseling prior to cystic fibrosis DNA screening?
Cell-based screening. Yeah, that's aspirational goal. That would be nice. But we did a quick analysis and found that if you were going to give about a 20-minute genetic counselor-based session for the general pregnancy population that might be tested, which is maybe 2.5 million pregnancies, that would take all the genetic counselors that are likely to graduate in the next 10 years. And clearly they have other things they need to do as well. So that might be an aspirational goal, but it's just not reasonable. And that was part of the reason we did our DNA First study, to show that with proper training, primary care providers can do this. They feel comfortable in doing it. We believe they do a good job. Again, we tested the women's knowledge and decision making, and they did as well as can be expected. Nothing's perfect, but they did reasonably. Most women understood what was going on with cell-free DNA screening after talking with their primary care provider. But thanks for the question.
Thank you for that answer. Our next question is, why is the cost of testing not coming down? I thought NGS was going to allow for a $100 genome.
Yeah. I noticed I've been to a few talks about next-gen sequencing, and I haven't seen that chart from NIH for a while. You remember the chart that started off, doing a genome was $3 million, then it was $1 million, then it was 500,000, and it came down in a logarithmic fashion, being cut in half or whatever every year until about 2010, 2011. And I don't think it's changed that much since 2010, 2011. So the idea of being able to do the sequencing for, all the sequencing you need for $100, has not arrived. And again, what many clinical laboratories are doing is adding. So if you want to do microdeletions, you actually have to do deeper sequencing. So even if the cost came down per base pair, you're doing more base pairs. So the cost is going to go up because of that, but maybe down because of the sequencing costs. So I think there has to be a different way of doing it. And I showed you, two methods that don't follow the standard path of next-gen sequencing that's out there, the methylation-based and the non-PCR-based. Good question.
Thank you. Our next question is, the risk of invasive testing is lower than thought. Why screen when diagnostic testing costs about the same?
Well, that's true in the high-risk population, that cell-free DNA testing kind of is roughly the same price as an invasive diagnostic test, maybe a little bit lower now. But in the general population, most women are not going to have a diagnostic test. You saw that there are some groups that argue, let's make sure that the women are informed about the advantages of invasive testing or diagnostic testing. But still, in the general population, there are likely to be very few amnios avoided, whereas every woman is going to get a cell-free DNA test. So there's not the balance in the general population that you see in the high-risk population. And again, that may be why insurance companies are, professional societies are holding back a little bit in recommending testing in the general pregnancy population. Thanks.
I would like to once again thank Dr. Glenn Palomaki for his presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through July of 2018. You will receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us, and we hope to see you again soon. Goodbye.